Both of these options are guessing. Both of these options are dangerous, and both of them destroy our credibility. If we're going to claim this space, and I believe that we totally should, we need to actually earn it. Attention chiropractors, slayers of subluxation, unleashers of the imprisoned impulse, and protectors of the developing brain. Welcome to the Cranial Doc Podcast, where we master the work that actually changes lives. Craniopathy, nervous system-based care, and the business systems that let you scale without selling your soul. I'm Dr. Anthony Pellegrino, pediatric chiropractor, certified craniopath, and proud automation geek. Let's dive in. Let's say a parent walks into your office tomorrow and says something like, "We just went to our pediatrician. They said that they have a tongue tie. I have no idea what to do. We scheduled a revision." What do you do? Because I've been around our profession for a while, especially in pediatrics, and I'll tell you what I see most people actually do, and I think that neither version of this is good enough. Camp number one is they just look at it, maybe pull the tongue for a second and say, yep, looks restricted, referral for release. No scored evaluation, no functional assessment, just eyes and a gut feeling, and, well, my kid had a tongue tie, so they revised, and that helped, so that means that everybody needs to get that done. And camp number two is the response of, well, you know what? No matter how bad this is, the nervous system controls everything. So let's just see them 3 days a week for 12 weeks and see what happens. There's no evaluation, no baseline, no actual understanding of what's driving the restriction. Just frequency and hope. Both of these options are guessing. Both of these options are dangerous, and both of them destroy our credibility. If we're going to claim this space, and I believe that we totally should, we need to actually earn it. That means having a scored, reproducible evaluation process. No opinions, not living off vibes, data. So that's what we're going to talk about today. The Hazelbaker Assessment Tool for Lingual Frenulum Function, or the HATLFF, is developed by Dr. Allison Hazelbaker, who's an IBCLC and a PhD. I first heard this spoken about in chiropractic by Dr. Steph Libbs, who is amazing and has amazing pediatric practice, Webster instructor. She's in Focus Academy with me, and I heard her mention it, and I put it in the back burner. And then one day I was like, you know what? I guess it's time for me to learn a little bit more about that assessment. And I was like, holy shit, what have I even been doing for the last 10 years? This tool has been methodologically validated. It has content validity, retest reliability, interrelator reliability. It is the real deal. And what it does is it scores two different categories, looking at them side by side, not together and adding them together, but side by side. There's function scored out of 14. 7 different items, perfect score is 14. And that is the most important piece of the evaluation. Function weighs way more heavily than appearance, which is category 2. What the tongue can do matters significantly more than what the frenulum looks like or what the attachment point is. Only thing that really matters at most is how the tongue is actually functioning. I don't care where it's attached if the tongue can do what it's supposed to do. The second category, as I just mentioned, is appearance, which is scored out of 10. 5 items, perfect score is 10. Appearance goes next to the function score. It helps us figure out whether the functional deficits that we're finding are actually because of the frenulum or because of something else like, subluxation, right? That distinction is everything. And it's the part that most of us and most of them skip. So I'm not going to teach you how to perform the evaluation today. I'm going to go over those different points to make sure you're actually looking at them. Hazelbaker has a course that's like an hour, 2 hours long. It's $50. You can bang it out in an afternoon and then take some more time to actually learn it. And I'll tell you more about that when we get to the end, all right? So rather than going through how to do the exam, what we're going to go through today is just walking through every scoring category, reviewing why it exists, and how we can use it to change the decisions that we make in our office. So let's start by going through, of course, the most important portion of the exam, which is the function items. Again, 7 items, each scored 0, 1, or 2. This is where the diagnosis of tongue tie lives or dies. Number 1 is lateralization. Can the tongue move side to side? This is something that's reflexive. If the body and tip can both follow, that's a perfect score. If it's only partially, that's a half score. And if it's barely or not at all, that's a 0. Lateral movement is how the tongue manages the bolus during feeding. So without it, feeding mechanics are compromised right from the jump. So number 2, can the tongue actually elevate, which is typically when we do an evaluation, the only thing that people are looking at and they're just throwing it away. Can it elevate or not? Do the tip and edges rise from the mid-mouth or higher? To the mid-mouth or higher? Perfect score. Some elevation, but not perfect. That's a half. That's 1 point. Tip stays at the ridge or we're seeing dimpling in the blade when we try to reach it. That's a 0. So let's be clear about the dimpling thing. We're not talking about a posterior tie. What we're talking about is the lift, is how the tongue can create a seal against the palate. If there's no lift, there is no seal, and there will not be effective feeding. Number 3, extension. Can the tongue get past the lower lip or over the tip with ease? That's great. Only to the gum line, half score. Doesn't make it, or the anterior tongue humps and dimples because the frenulum is yanking it back, 0. Extension tells us if the tongue can reach and hold position. Spread. Now this one is hard. It starts to trip people up. Let's think of it as the blade of the tongue thinning out right before the central groove forms during feeding. Complete spread is a perfect score. A partial or moderate is half or 1 point. And if the tongue stays blocky or bunchy or doesn't have any thinning, that's a 0. Spread is what sets the cup. Without the spread, the cup can't form. And then without the cup, there's no pressure differential. And the whole feeding chain is effed. So that's cupping is the next one, which is the central groove. A firm cup with the entire ridge, perfect score. Side edges only, half score. If it's flat, bunchy, and no groove, again, that's a 0. This is where the actual pressure from feeding is generated. And a compromised cup means that the baby is working 10 times harder for half of the result. Next, peristalsis, the wave. Progressive contraction front to back. I mean, you guys know what peristalsis is, right? Smooth and consistent, that is perfect. Good score. If it's partial or it breaks down or it doesn't really, the peristaltic action doesn't really initiate cleanly, that's a score of 1 or a half score. Or if it doesn't happen at all, that's a score of 0. The tongue is thrusting forward instead of waving around, that's our 0. Here's a visual cue. If you see tight corners in the mouth and the jaw is doing this like piston type thing, the peristalsis is probably not working well. The tongue is probably retracted and then the baby is compensating with jaw force, which is going to be uncomfortable for mom. Next is snapback, which is the tongue getting pulled off the breast in the midline because the frenulum won't let it hold. Key word here is midline. If we're breaking the seal at the side, that can be like from a torticollis. Breaking the seal from a fast letdown is something else entirely. Snapback is specifically the frenulum pulling the tongue away. If there's no snapback, that's a perfect score. If it's periodic or every few sucks, that's a 1. And every suck or every other suck, that's a 0. You'll see a jaw snap that kind of corresponds with it. So that's the total of the function exam, and that's 14 points. And previous to learning about this, I'll tell you, I evaluated like freaking none of these, right? And there's probably a lot of cases that I referred that I maybe shouldn't have, that I could have worked with, and probably some cases that I didn't refer that I should have. And that's on me. When we know better, we do better, right? Just like our patients, when they know better, they do better, they make better decisions. And I'm just glad that I know this now. So the next is going to be our appearance items. Again, these are 5 items. They're scored as 0, 1, or 2. Appearance, and we'll get to when actually scoring the exam, doesn't diagnose the problem on its own. It will support or challenge what the function score is telling us. So first one is going to be the actual tongue shape when it's lifted. If it's crescent or slightly squared, that's good. If there's a slight cleft at the tip, that's going to be a score of 1 or a half score. If it's fully heart-shaped, that's a score of 0. The slight cleft and heart-shaped are not the same thing. They'll go over that in the course. They're kind of like orders of magnitude. So a slight cleft can come from tightness in the septum and not the frenulum. That's why it's 1 point. Number 2 is elasticity. How much give does the frenulum have when we put it to stretch? That's not a function score. That's just appearance. And that's something that really drives a lot of us when we're doing our quote exam, unquote, if we don't actually know what we're talking about with tongue ties. If it's very elastic, that's a 2. If it's moderate, that's a 1. And again, a 2 is perfect, a 0 is not. And if it's really locked down with little to no give, that is a 0. So this one matters a lot because elasticity compensates, and a longer, more elastic frenulum can offset a less than ideal attachment point. Next is going to be the length when it's lifted. Basically, the actual length of the frenulum. It should be longer than 1 centimeter. That's a perfect score. If it's about 1, that's a half. And if it's less than 1, that's a 0. We have to accurately stretch it to measure it accurately, and then to be able to actually know what's going on there. Next is going to be the attachment to the tongue underside. How much of the underside does the frenulum occupy? If it's less than 50%, great score. And this is when we took a look at appearance, most people are just looking at where the attachment is going on the actual tongue, and that's one of the major things they do for judgment. That was me. That's probably you. And just know that's almost nothing when it comes to a functional evaluation. So if it is occupying less than 50%, again, that's a perfect score. 50 to 75% is a score of 1. 75 to 100% up near the tip, that's a 0. That's just 1 point, right? The attachments closest to the tip are what we would be creating the most severe ties and the biggest functional deficits. But the attachment alone is not the problem. An anterior tie attachment like that is probably going to throw in, like, you're probably not going to see a good function score with that. But the actual attachment itself is not enough to decide whether or not this needs to be advised. Listen to that again and again and again and again and again. So next, we're going to have to talk about the attachment to the inferior gum line. Because it doesn't just attach to the tongue, it attaches to the gum line as well. If it's going to the floor of the mouth or well below the ridge, that's great. If it's going to the backside of the ridge, that's a score of 1. Top of the ridge, that's a 0. Assess relative to that baby, not every other baby that you've seen, of course. And that's appearance. That's 10 possible total points, which tells you whether the frenulum is structurally contributing to what you found on function, or if there's something else going on. So let's kind of talk about that if there's something else going on, what the score actually tells us, and what this IBCLC, who is, I think, the world's leading expert on this when it comes to the actual evaluation and knowing if there needs to be a revision or not, actually says. So a perfect score is going to be a function score of 14 with an appearance of 9 to 10. This patient is probably not coming in thinking that they have a tongue tie. If you're doing your evaluation, you don't even mention that. You say, congratulations, there's no tie. The tongue is doing its job. Move on. So the next one is going to be where the function maybe isn't perfect, but the appearance is great. So we'll say it's function score of 11 plus, but less than 14, and appearance of 9 to 10. The tongue is doing fine. The function is acceptable, but not great. If the parents are still seeing issues with feeding and development, it's not the frenulum really contributing to that because we don't see that there is any increased frenulum. It's something else. The tongue isn't functioning perfectly, but something else is driving that problem. It could be birth trauma. It could be cranial strain. It could be upper cervical dysfunction. It could be a cranial nerve issue. The bottom line is these kids freaking need chiropractic care. The tongue is not the villain. Do not treat it like one. Adjust the kid. Do your cranial work. Address what you find, what's actually causing the issue, instead of chasing a tongue tie diagnosis and referring them for a revision that absolutely doesn't need to happen. So then we start to get into the borderline area, which is a function of 9 to 11. So it's dropped and the appearance is dropped also. Not a ton, but appearance is dropped enough where we start to be concerned. Appearance is that 7 to 9 score. A function is 9 to 11. Hazelbaker herself calls these faux ties, okay? F-A-U-X, faux ties. So she says that this is often happening with babies who have torticollis, birth trauma, and plagiocephaly. There are structural issues here that are creating functional deficits, and it looks like the tie is the driver, but it actually might not be. Her advice here is to exhaust management strategies, where this is going to be things like body work before we consider revision, okay? Read that again. The tool, the developer of this tool, is literally saying that these kids need structural work first. That's going to be your palate, your sphenoid, your temporal bones, your cranial work, your chiropractic care, your dural strain and function. That is our work. the structures that directly influence tongue mobility and oral function. Nobody touches it at the depth that we do, so we need to get in there, do the work, and then have an outcome measure. We are expecting to see the score change by this much in this time. Otherwise, we might look to do something like a revision. The next one is the most important for us, which is going to be a function score. I mean, not the most important for us, but where we really start to get into, wow, we're looking at revision time, okay? A function score clearly below 11, an appearance clearly below 8. There is a tongue tie. But at this level, until it drops even further, we're not just firing off a referral. We are still starting with frequent, serious, high-level care, intensive cranial work. We go all in. This is also where, as a provider, you're all either making referrals, or if the parents start talking about bringing in other providers, you actively encourage it. I don't care if it's myofunctional therapy, craniosacral therapy, dynamic body balancing, even if it's not chiropractic. Anyone who can improve tongue function is allowed to come into this kitchen. Even though we are still the major cook, everyone can work on this. Unless what they're doing is actively going against the work that we are doing, but that's your call because you're the one who did the score evaluation. You're the one leading the team. You're the one tracking the progress. You are the quarterback. If that level of care doesn't change the picture quickly, we are referring for revision. And we are referring with scored data that the providers will respect. Last category, function 5 to 9 or less, and appearance 4 to 6 or less. Obvious tie, send for surgery. We don't have the option to work with this. It may change it, but it will not resolve enough. The kids need us before and after the release because the structural tension that contributed to the restriction doesn't just vanish with a snip or a laser. We need cranial work before to set the tissue up to heal, cranial work after to address what's still there. We need to make that revision and be the ones to do so because the time in which us trying to work with this, knowing that the actual hope of it improving enough is so low that the risk reward there, it's revision time, okay? Now, of course, it's our job to encourage and walk along with our parents, let them know what our clinical picture says, and support their decision. We don't force them to do anything, but we have a, hey, if I were in your shoes thing, this is something that we need to address right away. So let's look at the full picture. The only cases that go straight to the blade are the most extreme scores. Every other category, the tool says to manage first. Work the structure, reassess, and let it be you every single time. So if you want to learn the full evaluation, how to score each item, and how to elicit the baby's actual best performance using things like reflexes to be able to do lateralization and a different score like that, just search the Hazelbaker course online. It is $50. Their website kind of sucks, so it's like annoying to get that, but just pay the $50, figure it out, watch the course. Score 30 babies, and by the time you're done, you could do this whole screening in like less than 3 to 5 minutes and really have the nuance locked in. Pair that with your cranial subluxation evaluation, and you are now the most thorough, most credible provider in the room on every tongue tie case. So stop eyeballing it. Stop hiding behind the nervous system controls everything without doing the actual clinical work to back it up. Score it, track it, and own the work. And if this episode has changed how you're thinking about these cases, do me a huge favor. Of course, subscribe, rate, review, and send this podcast to a doc who needs to hear this. I am out here trying to get the best pediatric and cranial chiropractors in the world to get more people face down, or in these cases, face up, getting evaluated and really trying to change our profession and world from the inside out. So that is it, and I'll see you all next week. Thank you for listening to another episode of the Cranial Doc Podcast. I hope you got a ton of value out of today's episode. And if you did, it would mean the world to me if you jumped over to iTunes or your favorite podcast player of choice and subscribed, rated, reviewed, and shared this episode with a friend that you know could benefit. We have a ton of this information and more in our free email series at thecranialdoc.com. So go ahead and jump on there, subscribe, and get me raw, unfiltered in your inbox every week, changing your practice. Can't wait to see you for the next episode.